Keith, Richard, Respiratory Associates, thank you very much for having me here again. You keep calling me back and I appreciate it. So thank you very, very much. I'd like to welcome everybody for taking the time out on this Monday to come and obviously get a CEU, but maybe hopefully learn something about drugs. So we're talking all about pharmacology, pain management, being our narcotics, sedation, and neuromuscular paralysis. That's the topic that is on today. Here's our objectives. So you're going to be asked if I met these at the end of this. Here's what my goal is today, is that by the end of this, you can identify the indications for narcotic administration, as well as the indications for sedation, indications for neuromuscular paralysis, describe potential hazards for each. This is probably going to be the highlight of the conversation today, and then recognize the appropriate reversal agents for each of these classifications of medications. Now, before we get into talking about that, why pharmacology? Why, when asked, you want to do a lecture, did I say, yeah, let's do one over pharmacology and let's talk about traditionally what we think about as non-respiratory therapy, pharmacology being narcotics, sedatives, and neuromuscular blocking agents. Well, we're going to get to that here in just a little bit, but the reason and my why for this talk is because when I was a student going through my educational process, I absolutely despised pharmacology. It was probably by far my least favorite class. And then I went out and started working in the field of respiratory therapy. Been a respiratory therapist now for 21 years. I spent the first 10 years of that working primarily trauma ICU and ER adult medicine, right? And so I realized that when I look back on that time, I really didn't understand the drugs that I was a part of. And that's one of my whys. The other why is just to show you how karma sneaks up and gets you sometimes. I started teaching back in 2011, and they said, hey, here's your class for next semester. And guess what it was? Pharmacology, right? So I got to teach my least favorite subject when I became an educator. And then I fell in love with it. And now it's probably my top 2 or 3 class to teach when working with students of respiratory care. And here's why. Here's why it's my most favorite subject to teach. Because as respiratory therapists, there's some thoughts here that I feel like we miss sometimes, and some nuances that we've got to get better at and understand. For example, when we think about the administration of a short-acting beta agonist and a patient who might also be receiving a long-acting beta agonist, a lot of facilities have these protocols that say, okay, well, if you ever have albuterol ordered at the same time with Perforomist or maybe Brovana, right? Or Formoterol, whatever they are. Then what do? We give this one and then we wait an hour. Well, people start saying, well, why do we have to wait an hour before we give the LABA? And the answer is, well, because these 2 drugs are targeting the same receptors. And so if the short acting takes up all the parking spots, then where does the long acting park? This is a great question, right? The problem with this is that nobody asked this question when we give albuterol and Symbicort. Formoterol is in Symbicort. We give the albuterol, we follow that up with Symbicort administration. Nuances, right? What are we doing here, right? Same concept with a short-acting muscarinic antagonist such as ipratropium bromide. We give these 2 drugs in Dulaneb all together, albuterol and ipratropium bromide. Perfect. And then we follow that up with a Spiriva administration. How come this conversation right here doesn't apply to both of these nuances? And that's what the focus of today is going to be on is the details of these drugs, not so much the big overall picture of them. Okay. Now, the other thing we come down here and we find when we think about respiratory therapy pharmacology is that we know that anytime we administer a corticosteroid, we rinse. So if you have somebody who receives an MDI of a Pulmicort, whether they call it turbohaler or a Symbicort, then everybody says, we rinse our mouth afterward, right? How come I get emails almost every single day asking me, if I give aerosolized Pulmicort, aerosolized budesonide from the aqueous solution, do I have to rinse? Of course you do. They're all inhaled corticosteroids, right? But we find these little differences that creep in that we don't treat all these drugs the same. What about the administration of a beta-2 agonist in the presence of a beta blocker? This is probably most likely in your cardiac tower, right? Got all these patients out here on beta blockers. We know that they're not specific to just beta-1. And here we are giving a beta-2. So are we trying to block the beta receptors, or are we trying to ignite the beta receptors? Questions. What are we doing here, right? And then the last one here I have before we jump into our main point of topic is oxygen therapy. Probably one of my biggest pet peeves in the world of respiratory therapy is oxygen therapy. This is the most given and administered drug in the hospital setting. How do we go through our shifts? We go in, we find a patient, we're doing an oxygen check, we put the pulse ox on them, 2-liter nasal cannula, they're satting 88%. What do? We turn it up to 4 liters, right? We just turn it up. And then we go to the next patient. The question is why? What other drugs in the universe can you just haphazardly give more of without having to document it or even put it on a MAR, right? We don't even document this on the medication administration record when oxygen indeed is a drug. So you can see kind of just some of the little details that get me excited about talking about how we can all be better at pharmacology. Now, this last point I pointed out here about oxygen therapy, what if anytime you have to increase that oxygen from 1 to 2, 2 to 3, 3 to 4, 2 to 4, whatever it is, what if you said, you know what, this is an opportunity for an intervention because this person now needs more oxygen. Why? Why do I have to give this person more oxygen? And what if we took 10 to 15 minutes trying to figure out, putting the pieces of the puzzle together that are warranting this need for more of a pharmacological agent? That's the question. And not only am I asking that question, but there was an article that came out in either the September or the October journal of the AARC Respiratory Care Journal, written by Robert Chatburn, Richard Ford, Gary Kaufman. If you know those 3 names, you know these are leaders in our industry. And the title of this article was Determining the Value Efficiency of Respiratory Care. Now, how is this going to play into this whole conversation? Give me some time and I'll make it make sense. But basically what this article said is that we have got to shift our mindsets from being task doers to being doers focused on outcomes. Everything we do. Go back to that last set of questions I asked. Every single one of those questions, what impact does this make on the patient's outcomes? And this article goes into saying that this has been a topic that's been around for a long time. People saying we've got to move from productivity to value-based. And they're still going to keep repeating it until we get there because we have to become outcomes driven. Now, in the topic of these conversations that we're going to have today, we respiratory therapists take care of patients in the ICU commonly. And a lot of times they don't like the way we're mechanically ventilating them. And so they become asynchronous. And this statement right here has come out of my mouth multiple times, as well as heard from other respiratory therapists multiple times. And it comes out like this. Oh, the patient needs more sedation. That's the answer to the problem. They need more sedation. This article talks about the value efficiency of what we do to shifting this mindset right here to this mindset. What can I do to aid this patient to reduce the need for more sedation? See, we shift our focus here. I just want to give more sedation. Why do we need to? And is there something I can do as a respiratory therapist to maybe perhaps not have to do this? Okay, what can I do to reduce the need for sedation? So that's kind of where this kind of comes from in these topics. Now, with that in mind, I want you to keep this question in mind as well. What monitoring tools, these are monitoring tools, can you, the respiratory therapists utilize to improve patient outcomes associated with the administration of the drugs we're going to be talking about: narcotics, sedatives, and paralytics. Keep that question in mind because we're going to come back to it in just a little bit. Okay, now let's jump into each of these categories. The first one we're going to talk about is narcotics. And when we talk about narcotics, the first thing you got to recognize is we're talking about pain. So you can see here, if this was a real person, they're probably hurting, right? And we've seen this patient before. We've gone into the room, we're going to do a metaneb or an IPV or an incentive spirometry, and they go, stop, I'm hurting too bad. I'm hurting too bad. Like I have a flail chest, right? I'm in some severe pain here, and I'm not doing any deep breathing or coughing. And we say, okay, well, we'll coordinate this with the nurse so that we do this therapy while they are receiving their pain medication. Now, the pain medication they're receiving, when we talk about narcotics, a few to name here is morphine, fentanyl, and hydrocodone. So they get these drugs. Now that they've got the drugs, it's our job now to go in there and say, okay, well, now let's get you doing some deep breathing. Let's get you coughing, right? Because you've got your pain medicine now, right? What we have to remember is that these drugs come with hazards. And the hazards of these drugs, the problems that you need to identify when we talk about narcotics, is that these drugs affect the neural drive to breathe. This comes from the medulla oblongata. When that happens, we get a reduced neural drive to breathe. Now, if the signal to breathe from the neural drive is decreased, then guess what? The function of the diaphragm decreases. This is where we're talking about external respiration, gas exchange at the alveoli, secondary to the work of the diaphragm. If this is decreased, then how do we maximize external respirations for the sake of maximizing internal respirations? We have to ask ourselves these questions, right? So I go back to it. Let's coordinate with the drugs, which is fine. I'm not saying we shouldn't. What I'm saying is how many of these patients haven't been shown how to splint? How many of these patients haven't been given a pillow and shown how they can hold and hug so that they're not always having to get a narcotic prior to deep breathing and coughing? This is something that should be happening routinely. Should they routinely be getting these drugs all the time to a point that it causes this decrease in neural drive? Now, you got to be ready for this because this patient can also be coming out of surgery. They come from the PACU, anesthesia hit them with 10 of morphine before they came out. And then they got to the floor and the nurse said, don't worry, I got you. You won't be hurting. And they give them another 10 of morphine, right? We just got double dose of narcotics on arrival to the general floor area. And now we get called for a rapid response because the patient's not responsive. They're hypoventilating, they're hypoxemic. And now we have an emergency situation on our hands. Now, what we know is that there are drugs that we can give that can reverse this effect right here. Too much narcotics can depress the neural drive to breathe, but we can reverse this. The drug is naloxone. Brand name is Narcan. Remember, Narcan, narcotics. These drugs go together. Now, when you give this drug, recognize that the patient is going to go from lethargic, no pain, to having that sensation of pain again. So there's still going to be a need for a focus on pain management. I'm not saying that these drugs are a problem. I'm saying appropriate administration of these drugs are the goal. And how can we be a part of that? Okay, we're going to talk about that as we move forward. So this is narcotics. Remember, pain, we're going narcotics. These are our three big ones here: morphine, fentanyl, hydrocodone. Narcan is the reversing agent. Do not forget they can depress your respiratory drive to breathe. Your patient can become acidotic. Now, the next group we're going to talk about are benzodiazepines. Now, these are our sedatives. These are our drugs that exist to reduce fear, anxiety, discomfort from these feelings of I'm scared, not pain. Actually, research actually shows that if you have a patient that presents with pain and you give benzodiazepines, that it can actually enhance the feeling of the pain. So we have to recognize that there is a difference in a patient first that is hurting versus a patient that is scared. Two different indications. When we are scared, fearful, anxious, I'm just going to put scared up here, we're thinking our sedatives, our benzodiazepines. Now, this comes with several different ones. The list is much longer than this, but I just put a couple of the big ones up here. Midazolam is Versed. This is a big one we see, right? How many of our patients get 5 of Versed? 5 of Versed, right? Propofol, brand name Diprivan. We know this. This is the one that hangs up there in the ICU. Looks like a little jar of milk, right? Call it milk of amnesia. And then lorazepam is Ativan. Okay, all of these drugs are in the same category that exist to reduce this sensation of anxiety and fear related to procedures. Here's the kicker. These drugs can also reduce, suppress, depress the neural drive to breathe. So too much of these, and now our patient's neural drive to breathe will be suppressed, which it's going to come down here and cause our pulmonary mechanics to decrease. Again, these patients can become acidotic. Their CO2 goes up, their pH goes down, their PO2 starts to fall. Why? Because patients can become hypoxemic in the presence of hypoventilation. So this is why we see all these things, right? Our patients begin to hypoventilate. Again, appropriate administration to reduce the feeling of being scared, but not to the level of suppressing neural drive to breathe, because that comes with complications. And we're going to see here in just a little bit, it also comes with worsening patient outcomes. Now, just like we talked about with narcotics, we see here when we're talking about our benzodiazepines, there's also a reversal agent, but it's different than it was for our narcotics. When we talk about benzos, our reversal agent is flumazenil. This is romazicon. Okay, so this drug will reverse the effects of these drugs. Now, your patient's basically going to go from feeling really, really good to feeling really, really bad, really, really quick. So all of these feelings that were being treated with these drugs, and this can be intentional or not intentional. If you've worked in any facility, you've probably had a drug overdose patient before present to your emergency room. And perhaps you heard the paramedics say something like, we gave her Mazicon with no response, or we gave her Mazicon with a response. Well, if they responded to the Romazicon, the flumazenil here, right? Then we know that it was one of these drugs, along with many others that aren't listed, that might be the drug that they ingested, maybe too much of, either intentionally or unintentionally, that's created this drug overdose situation. Now they're awake, alert, combative, and not happy at all. So do we need to treat that? Absolutely. But understanding that these drugs here led to the reason that they were found non-responsive, barely breathing. EMS was called. Now they're here with us, and we have to treat them. Okay. Now I will tell you this. There is, these are drugs that we give all the time, especially during mechanical ventilation. So we know that these drugs help to increase patient ventilator synchrony. In excess, these drugs also make coming off the ventilator extremely difficult, along with the narcotics. If we give too much of any of these drugs, you're going to have a hard time getting these patients off of mechanical ventilation, especially in the presence of extreme ages, end-stage renal disease, liver dysfunction. Those type of things are going to reduce the clearance of these drugs, and you're going to be sitting there going, we've stopped the medication yesterday and they're still not awake. They still aren't breathing spontaneously. Well, why not? Because of the administration of these early on. Now, I'm not here to say if it was appropriate or excessive or whatnot. Just recognize that these drugs have a lingering effect until cleared. And until they're cleared, this is going to be a problem. ultimately all the way down to what you were looking for a good arterial blood gas and good pulmonary mechanics during the weaning phase. So keep that in mind as we talk about benzodiazepines. You look to treat your patients appropriately with these sedative medications. Okay. Now, before we move on, I knew there was something. There is a newer drug that falls in this category that I want you to remember. It's called Precedex. Precedex claim to fame is that it can reduce the fearfulness and the anxiety without affecting, or at least with a reduced effect on the neural drive to breathe. So we're seeing this drug used more often. You as the respiratory therapist, this is something that you need to be aware of so that you can maybe recommend this. Talk to your care team and say, hey, we need to get this person, everything looks resolved. We're having a hard time them tolerating an SBT because when we stop the propofol, they become completely restless and combative, and I can't even perform a proper SBT. In that situation, we usually do one of two things. We either extubate them and hope for the best, or we resedate them. Sometimes this resedation cycle goes on for days and days and days, and they end up being trached. What if a simple switch to a benzo that does not affect the neural drive could keep them calm during the spontaneous breathing trial to then allow us to assess their pulmonary mechanics and get them extubated without the need for a tracheostomy tube? Oh, don't even go that extreme. Maybe just without the need for another 48 hours on mechanical ventilation. What if, right? So keep Precedex in your back pocket. Keep it in mind anytime you want to remember it. Now, when we talk about neuromuscular blocking agents, these are our paralyzing agents. Now, I know I got fancy up there, neuromuscular blocking agents, but that's what we're saying. We're talking about drugs that paralyze your patients. It makes their skeletal muscles incapable of movement. This includes the diaphragm. Here's what I want to show you. We've got now this right here is not an image. This right here is actually an image of what I feel like people might think about this if they're not properly sedated during this process. Okay, so I'll explain that here in just a second. Here we're talking about Nimbex, vecuronium, nectine or succinylcholine. There's also rocuronium, pancuronium, all of your neuromuscular blocking agents. But these are three of the ones we hear routinely. Remember that succinylcholine is very short acting. So this is the one that at one time was very popular to be used during the administration of, to be used during or administered during the need for intubation. So we would give them succinylcholine, patient would become they'd become paralyzed, we'd intubate them, and then 10 minutes later, we're wrestling with a patient because this has worn off. The rest of these have a much longer half-life, so they last much longer. Succinylcholine is your short acting. You got to be ready for that as an RT. You're standing at the bedside and you hear sucks is given, sucks is in. Then in your mind, you have a clock that's going. Your stopwatch has started. 10 minutes. And we got to either be done with this procedure and moved on to a new type of agent that is keeping this person calm, or we're going to have a potential emergency situation on our hands. Now, what I really want to point out about these drugs is that these drugs, while they paralyze skeletal muscle, they do nothing to eliminate or reduce the neural drive. So all of this stays intact. You see, this is all neural signaling. So this is not based off of skeletal muscle movement. In other words, if you give a patient neuromuscular blocking agents, any of these, and you do not properly treat their pain or potential pain, nor their anxiety or their sedatives, they essentially will be freaking out in their head, trying to breathe, but completely unable to because their skeletal muscles are paralyzed. They will feel the discomfort of the ABG. They will feel the discomfort of the intubation. They will feel the discomfort of the mechanical ventilator. They'll feel all of this because we're not taking away their sensory mechanisms. So how does it affect the pulmonary status? Well, it doesn't change this, but what it does is it blocks the movement of the diaphragm. The signal gets sent, but the diaphragm is completely paralyzed. And so there are no respirations that can be had. Despite, think about this. Think about how terrible this sounds. You receive a neuromuscular blocking agent and not the other agents, which is where we become patient advocates, which is where we could say, wait a second, are we going to give the vecuronium now before the morphine and Versed? That order seems not correct. Like, I feel like we should make them pain-free, comfortable, anxiety-free before we paralyze them. Because if you don't, then they're perfectly aware of the fact that they cannot breathe right now and hearing everything going on around them. So this is very, very important to me. This, you can tell I'm very passionate about this. This right here is a problem. Understand that this of the three is different because it doesn't affect that. Now, what we do know is that a lot of times patients come out of surgery and they have received these neuromuscular blocking agents during surgery. And that's because it enhances patient synchrony. You don't want your patient responding to every cut, every suture, everything during surgery, even with sedation. So we paralyze them, and that's appropriate. They come out of surgery and they are still paralyzed in a lot of instances. Or you will hear the anesthesiologist say something like, edrophonium was given or neostigmine was given. Reversal agents have been given. And that in itself, these drugs will reverse the impacts of these drugs, okay? Which is good, because if we want to get that person extubated and off of mechanical ventilation as soon as possible, we need to understand that these drugs have been reversed and no longer have an effect. We don't want to go to CPAP or a spontaneous breathing trial with the effects of these still lingering. That would not lead to good outcomes. The patient would be apneic, even though they're trying to breathe, and you would be impossible to get them off of mechanical ventilation. So you have to recognize that these are the paralyzing agents. These are two examples of drugs that reverse that. Now, if you're wondering, like, well, where does this face come from? It's because this is how I imagine you feel with these drugs on board without proper pain and sedation. And I've said that multiple times, and that's because it's so important to me. I can't tell you, and a lot of people here, you can probably tell me in the chat if you want to put it in the chat. You can probably attest to situations where you've had a patient who is receiving neuromuscular blocking agents. And what you find is that when you're suctioning them, you see a tear come out of their eye. We got to ask ourselves, do they have enough sedation on board for what's happening right here? Like, there are signs and clues to know if everything is being treated appropriately. That's why I'm going to challenge you to be the RT that explores those areas, okay, and becomes that patient advocate for your patient. If they're hurting, narcotics. If they're anxious, sedatives. If we can't fix it for whatever reason, if they're paralyzed, know this so we can serve them the very, very best with outcomes in mind. Okay, I told you and I presented you with this question earlier. I'm going to ask you again, what monitoring tools, we're talking about monitoring tools, can you, the respiratory therapist, utilize to improve patient outcomes? Circle this too. Patient outcomes associated with the administration of narcotics, sedatives, and paralytics. Now, when I ask it this time, I'm going to frame it just a little different, okay? I'm going to shift your focus to what can we do when these drugs are being given to what can we do to think, how do I serve this patient better? That's the question. If you want to put them in to the chat, go ahead, tell me what you're thinking. I have a list for you. And that list is right here. Of course, we know pulse oximetry, right? Everybody gets a pulse oximeter. Well, almost everybody. But we know pulse oximetry is a proven, non-invasive monitoring tool that can be used to help us identify hypoxemia when it happens and when it begins to occur. We can use this tool. This is a good tool. Question: do you think it's better than end-tidal CO2? Do you think it's better than capnography? If you say no, then the question is, why don't we use this more often? Because it's 100% a tool that is going to be an earlier indicator of hypoventilation rather than pulse oximetry. So this is interesting right here. I'm going to show you some research revolving around these two here in just a little bit. This next one here is point of care ultrasound. So this is probably, in my opinion, probably top 2 or 3 technology coming to fruition here that's going to directly impact our lives as respiratory therapists. And I know what you think, well, I didn't go to school to be a sonographer. No, you didn't, but guess what? You're going to find quickly that this right here is coming to the bedside. Point of care ultrasound. You know what we can do with point of care ultrasound? We can measure the thickness of a patient's diaphragm. Think about that. We can measure the thickness of a patient's diaphragm. Well, how is that even beneficial? Well, it's beneficial because if you go back to these drugs that we just talked about, and if we depress the patient's ability to breathe spontaneously, and that reduces the diaphragmatic response, or if we paralyze and they can't use their diaphragm at all, then what do we know starts to happen very, very quickly after this process? The diaphragm begins to atrophy. It begins to weaken very, very quickly. We can measure that with point of care ultrasound. Guess what else we can do? I've kind of been talking about over administration of these drugs. Let's just go back to maybe when we don't give enough of these drugs. Maybe we're neglect on recommending it when we need to. So I want you to recognize there's a balancing act here. I'm not telling you to never recommend sedation. I'm telling you we have to do it very intentionally to a point that best serves the patient. Because if we don't give enough sedation, if we don't manage pain enough, then we know that respiratory drive will increase. If respiratory drive increases, then guess what? We can see diaphragmatic hypertrophy. Either of those are bad. We need our diaphragms to stay basically like they are right now when we are healthy and living our day-to-day life. We don't need them to get weaker, thinner, lose strength, and we don't need it to thicken and become, too strong. We need it to be right where it's supposed to be. Point of care ultrasound, we can measure with it. Again, I've been a respiratory therapist for 21 years. It's the first time I've ever been told that, hey, guess what? You can measure your patient's diaphragmatic thickness to indicate hypertrophy or atrophy, which I think is really, really cool. Sedation, pain management, neuromuscular blocking agents directly impact that. This is one of my favorite topics in the entire world, ventilator graphics. I love the use of ventilator graphics. And remember, the question is what monitoring tools do you have to better assess the patient receiving these drugs? Ventilator graphics are your perfect tool because ventilator graphics are where you can see asynchronies happening. This is oftentimes when you have that patient who is in a state of discomfort and we want to just go right away, like we just need more sedation. Well, wait a second. Let's just slow down here for just a second. What if we assess their ventilator graphics and we could identify flow hunger? What if the patient just wanted a little bit more flow? And that would calm them down. What if we actually thought about using the graphics to better set the ventilator to breathe like the patient? Not give more medications to the patients so that they breathe more like the ventilator. That's not the goal here. Remember, the idea of this started with how can we impact patient outcomes? Ventilator graphics. You can easily recognize flow hunger. You can easily recognize double triggering or breath stacking. And I get in this all the time, and I work real hard here not to go down a rabbit hole, but we have patients in ACVC all the time that are breath stacking, and they're on a tidal volume of, let's say, 450. And now they're taking 2 breaths back to back to back, right? Now their tidal volumes are 900. We're peak pressuring, and we say we need to give more sedation. What if the patient just wants 470 milliliters? But because they are still triggering at the end of the 450, now they get 900, and the patient has no idea what's going on. They're freaking out. This is even making everything even more exacerbated. And we give sedation so that they'll be happy with the 450. Those are the things that you can see with ventilator graphics. Now, occlusion pressure has to be on this list because we can recognize and actually measure and have an objective assessment of our patient's neural drive to breathe. Remember, these drugs we've been talking about, narcotics, benzos, they reduce our patient's neural drive to breathe. Well, what if we're trying to extubate them and they have no neural drive to breathe? Guess what? We can assess that. We can say, you know what? Maybe it's time to cut back on the sedation. Maybe it's time to cut back on the morphine because we have no neural drive. How do we want to get them extubated with no neural drive? It's not going to happen. What about when they're going to administer neuromuscular blocking agents? They're going to give Nimbex to a patient. And before they do that, what if, just imagine a world where you as an RT went into the room and said, hey, before you give that Nimbex, can we do something here? I want to assess the patient's occlusion pressure. And if you see that they still have an increased occlusion pressure, which means an increased neural drive to breathe, or even a neural drive to breathe at all, what if you said, hey, can we give more sedation to take away that neural drive before we give a neuromuscular blocking agent? Because remember, the neuromuscular blocking agent doesn't remove the drive to breathe. It just removes the diaphragm's ability to respond to the neural drive to breathe. Does it sound fun to have a neural drive saying, take a breath, but you can't? Even during mechanical ventilation when everything looks perfect? Absolutely not. So occlusion pressure, super valuable in helping us to further recognize the effects of these drugs on our patients. And the last one here is the RAS score. This is the Richmond Agitation Sedation Scale. Richmond Agitation Sedation Scale. Know what you're thinking? Like, I've heard nurses say that before, but I didn't learn about that in school. Well, we typically don't, because this is typically seen as a nursing scale. This is something that they do on a routine basis. But what if we got better at it? What if this became something that we also utilized to help us better take care of our patients? To say, hey, you know what? I've got flow hunger on my ventilator graphics. I've got an increased occlusion pressure, and we've got an elevated RAS score. Let me try to fix this before we just treat it with more drugs. Okay, so these are just a handful of tools that we can use. And you don't have to believe me, because this is all rooted in research. Now, I know you can't read all of this, so I'm just gonna summarize each of these for you, okay? This first article up here talks about sedation intensity in the first 48 hours, and then they compared that to the 180-day outcomes and mortality rate. Guess what they found? Probably don't even have to say this, do I? The more sedation a patient receives within the first 48 hours of admission to an ICU led to worsening patient outcomes at the 180-day mark. Increased mortality, increased length of stay, increased ICU days, increased ventilator days. All based on, independently related to, sedation amount in the first 48 hours. What can we do to flip that? What can we do to change that? The second one here talks about a discordance between respiratory drive. We've been talking about this, respiratory drive and sedation depth in critically ill patients receiving mechanical ventilation. Now, this study is very interesting because we know that when we have these patients who look asynchronous and uncomfortable, we have a tendency to say, give them more sedation. They're not happy, give them more sedation, right? I mean, it's been an underlying theme throughout the entire 41 minutes here, right? Guess what this article showed? It showed that even with an increased depth of sedation, there was still a notable increase in patients' neural drive to breathe. So we maybe made them look good in the bed, but did we really satisfy them up here at the neural level? Think about that. That's interesting to me. This one here talks about, actually the next two here talk about capnography being superior to pulse oximetry. And then this one here is the respiratory rate and capnography are superior to pulse oximetry. So two studies here that talk about the use of capnography, and then a novel concept here, actually counting a respiratory rate is a better indicator of impending ventilatory failure and hypoventilation than pulse oximetry. And I touched on this earlier, I'll repeat it once again. And that's because hypoxemia occurs secondary to hypoventilation. So the pulse oximeter is picking up something that is happening after a rise in CO2 and a reduction in pH. So by the time the pulse oximeter is telling you your patient's hypoxemic, they're already hypercapnic, which is why the use of capnography and end-tidal CO2 monitoring is extremely important. I'm going to wrap this up here real soon, but I want to highlight this case right here because I think this drives it home. If you're familiar with the Vanderbilt University Medical Center legal case that's been going on now for the past several months, this is the Rondavant trial that's been happening. And we know that Rondavant gave a patient a paralyzing agent. The patient was nervous to go into a CAT scan. And Rondavant, the nurse, gathered a verbal order for Versed. She goes to, so she got an order for Versed. She goes to the Pyxis and overrides to pull this drug out. She types in VE and pulls the medication that pulls up. The drug she pulled was vecuronium. Now, this is why this case or this presentation has been full of generic names. You never saw Versed in this presentation because we know Versed's generic name is midazolam. And that's important. Even for us as respiratory therapists, we've got to recognize that when we are working with drugs in a hospital setting, we are going to be utilizing generic names, not brand names, because this is what happens. The patient was to receive Versed. Instead, she got vecuronium. She went into the CAT scan. She coded. She was revived, but she eventually passed. The nurse, key point here, was charged criminally with reckless homicide and just recently found guilty. Now she's been sentenced and all that stuff since. The point of this talk is not to point out what happened in that case. It's to point out and to ask you a question. What would you do if you had been there? And what will you do in the future, knowing that this type of situation could happen? What could we have done as respiratory therapists to prevent this from happening had we have been present? And the answer is simple. Wait a second. They're going to receive a benzodiazepine? Okay, I'm sorry. Oh, they're going to receive a narcotic. Or they're going to unknowingly receive a paralyzing agent? Then guess what we need to do? Before you administer, I'm going to implement some type of monitoring device because my desire to have a positive outcome on this patient exists. And so I want to monitor this patient because any drug that you're about to give can affect their ability to breathe. And I want to monitor it as a respiratory therapist. So keep that in mind. Big case, probably already seen it. And how do we make it relevant to us, right? Here's the summary for this presentation. Remember, narcotics are used to treat pain. Pain is your indication for these drugs. Morphine, fentanyl. Your reversing agent was naloxone. Brand name is Narcan. Your benzodiazepines are used to reduce anxiety, stress, fear it's scary being in a hospital. These are the drugs that reduce those fears. This is your Versed, your Ativan, your Propofol. Remember Precedex. They can all be reversed with flumazenil, which is romazicon. And then our neuromuscular blocking agents, oftentimes give them to increase patient synchrony with surgery or even during mechanical ventilation. This is your Nimbex, your Vecuronium, succinylcholine during intubation, those type of drugs, pancuronium, rocuronium. Remember that these drugs remove the ability for the diaphragm to contract, but they do not take away your patient's mental sensory mechanisms. Your neural drive to breathe stays intact. And then finally, what I've challenged you with several times now is, what can you do? What can you do to become an advocate for your patients during any administration of any of these drugs? But you know what? Just take it even further. What can we do to be a better advocate for our patients across all spectrums to improve and impact patient outcomes? That's where we have to go. That's the article, Determining the Value Efficiency of Respiratory Care, is wrapped up in outcomes, and that's where our future lies. Thank you for being here. This is where you can reach me. I'm on all the socials, Instagram, TikTok at Respiratory Coach, Twitter at Coach RRT. Send me an email. We're going to have a chance for Q&A here in just a second, but if by chance you want to further this conversation beyond the time allotted for that, respiratorycoach@gmail.com is where you can reach me. And I would love for you to send me a text to 817-968-7035. This is a texting platform that I have, and just send out occasional messages, inspirational, educational, motivational, just to say, hey, I'm thinking about you today, with the hopes of just inspiring and promoting the growth of this wonderful field of respiratory care, which is where I, like yourself, make our living at, and just trying to bring it all together towards a common goal. So that's where you can reach me. Of course, you can always reach out and find other information and educational lessons on my YouTube channel as well, which is Respiratory Coach.